Ask the patient to lie down on the flat bed. Warm your hand and inspect the skin for scar, stains, dilated veins, rashes, chymosis. Inspect the symmetry and contour of the abdomen. Observe the contour of the umbilicus to look for signs of inflammation and hernias or paralysis or aortic pulsation visible in the epigastrium. Place the stethoscope gently on the diaphragm and over each quadrant to listen the abdomen before performing the percussion, because these measurements may alter the frequency of bowel sound. Occasionally, you may hear the normal stomach growling. If the patient has high blood pressure or atherosclerosis disease, listen in the epigastrium over the aorta and over the iliac artery and femoral arteries. Next, lightly percuss the abdomen to assess the distribution of tympani and dullness. Tympani is a high-pitched musical sound that indicates a hollow space filled by air or gas in the stomach or intestine. Dullness suggests flues or underlying organ like the liver and spleen. Palpate the four quadrants of abdomen, beginning gently and saving painful areas for last with your finger together. Place your hand flat on the abdomen and press using a light dipping motion, moving smoothly. Palpate all quadrants, identifying any tenderness or increased resistance to your hand. If the abdomen muscles are tense, then try to relax the patient and try to palpate again. Having patient flex the knees is often helpful.
Palpate by pressing more deeply in all four quadrants as you feel for any masses or tenderness, placing one hand on top of the other. Watch closely for signs of an acute abdomen from inflammation of the parietal peritoneum or peritonitis. Signs include abdominal pain with coughing, rigid or board-like abdomen, guarding, rebound tenderness, and percussion tenderness.
Percuss the swan of the liver. First, locate the mid-calval line. Use a light moderate percussion strike, starting at the level below the umbilicus in the right lower quadrant in an area of tympani. Percuss up toward the liver. Identify the lower border of dullness in the mid-clavicular line. Next, identify upper border of liver dullness starting at the nipple line. Lightly percuss from lungs resonance down toward liver.
Place your left hand behind the lower thorax, lifting up the 11th and 12th ribs overlying soft tissues. Place your right hand just below the right upper quadrant, lateral to the rectus abdominis muscles, and well below the lower border of liver dullness. Hooking technique may also be helpful. Standing to the right of the patient's chest, place the fingers of both hands below the border of liver dullness and press in and up toward the costal margin. Ask the patient to take another deep breath.
Take another deep breath for me, please.
Hand flat on the right lower rib cage and gently strike it with the ulnar surface of your right fist. Ask the patient to compare the sensation
compared to this side.
Eyes. Reach over and around the patient with your left hand to support the left lower posterior rib cage and overlying structures. Place your right hand below the left costal margin and press in with your fingers toward the spleen.
Take another deep breath.
When the patient takes a deep breath, try to feel the spleen as it comes down to meet your fingertips. The tip of the spleen is palpable in only 5% of normal adults. Spleen is palpable in only 5% of normal adults. Alternatively, ask the patient to turn onto the right side with the legs somewhat flexed at the hips. In that position, gravity may bring the spleen forward and to the right into a palpable location. To help detect splenomegaly, an enlarged spleen, percuss the left lower anterior chest wall roughly from the border of cardiac dullness at the 6th rib to the anterior axillary line and down to the costal margin. This is an area called Traub space. As you percuss along this route, Note the lateral extent of tympany. If tympany is prominent, especially laterally, splenomegaly is not likely. Then ask the patient to take a deep breath and percuss again. Left side, and place your right hand behind the patient, just below and parallel to the right 12th rib with your fingertips just reaching the costovertebral angle. Lift, trying to displace the kidney anteriorly. Place your left hand gently in the left upper quadrant, lateral and parallel to the rectus muscle. Now ask the patient to take a deep breath. At the peak of inspiration, press your left hand firmly and deeply into the left upper quadrant, just below the costal margin, and try to capture the kidney between your hands. Ask the patient to breathe out, and then stop breathing. Slowly, release the pressure of your left hand, feeling at the same time for the kidney to slide back into its expiratory position. As for costovertebral angle tenderness, or CVAT, seen in pyelonephritis. Place the ball of your left hand on each costovertebral angle in turn and strike it with the ulnar surface of your fist. Normally, there is no tenderness over normal kidneys.